They all talked about you being on vacation.
They did.
Yeah. And how they wished they were with you.
I went to the taping of the, I was in New York. We went to the taping of his Colbert show. You watch Colbert at night?
I know who Colbert is,
who
but
he
I
is.
don't watch his show.
I don't watch him either, but he's a very funny
I'm
guy.
sound asleep by the time it comes out.
Well, they film it in the afternoon.
Yeah, I
They
know, but I'm
broadcast,
still
so-
sound asleep.
So they do it in the Ed Sullivan Theater on Broadway, which is where Letterman was. He took over Letterman's spot.
No, actually, I've been to Letterman once.
You've been to the taping of that
Yeah,
show?
yeah.
So you line up at about 3:30 in the afternoon.
Right.
They actually don't start taping the show till about 5:30.
Right.
And they do about 2 hours, and then they obviously edit it down to about 1 hour. And it's really a lot of fun to see how they put together a live TV show right in front of you. He blows a line, and he comes back and redoes it. And, I mean, he was popular when he was on Comedy Central, but now he just lambasts Trump constantly. His entire monologue was, but he's funny. And his career has just skyrocketed since Trump has been president. That's made his career for him. So
No,
it's a
no.
fun event.
You know, the interesting thing there is Trump is a president,
Yeah.
and you can make as much fun as you want, but he is.
Yeah, you have to deal with it.
Yeah, you have to deal with it, and that's all there is to it. And whether you like it or don't like it, this, that, the next thing, you got to deal with it. I like your attitude. You know,
Yeah.
that's what it is.
Well, he has to deal with it too. He came out and said it's a much harder job than he ever thought it would be. You know,
I thought it would be an easier job
Yeah,
than a harder job.
I don't think he realized. You know, when he ran his own business, basically, if he said do something, it got done. Now, when he says do something,
It's 50 senators. It's 200.
the
Congressmen
judges, the
or
legal
whatever.
system, the press,
Yep.
everybody's, you know.
I'm sure he's very frustrated.
So,
Very frustrated.
good morning.
Good lesson in humility.
Good morning. Okay, this is Ravens from Seattle Art Museum. They have the whole scroll, or half the scroll. And my wife's on the board of directors there. Yeah. You want it?
No.
Okay, they give it to you. It was free. So what I'm looking for is the, so you talk to pediatric patients about IT, right?
Me?
Yeah. Or whoever.
Yeah.
Okay. So why does there seem to be a difference between IT and biologics?
I mean, resistance to doing it.
Yeah, exactly.
Well, I mean, firstly, you don't have that many young kids. I mean, usually you don't start considering immunotherapy. It all depends on the maturity of the kid, but you know,
Nobody's come around and told you
injecting medicines into,
hard parts
I
of the
find,
body,
you know,
say,
anybody sort of under age 8 or 9 is a big resistance level. I mean, you go in and with
The kids or the parents?
the kids for sure.
Okay.
The kids for sure. And even at that, you know, if the parent wants to do it for the kid, there's often screaming and yelling and.
Oh yeah, I heard this. In a lot of ways.
And especially, it's harder, I would think even harder for immunotherapy if you tell a family,
Like I went to 6 different
well, you
locations.
need 25
Where do you ever
build-up
like,
injections,
you
you have to
just
come in
don't
once or
know.
twice a
They've
week.
got tons of rules. So.
The average kid, you know, under age 8 or 9 is going to put up such a stink that it's not practical.
Okay. Good.
I mean, at what age do you find that kids are receptive to injection immunotherapy?
Well, it started at 5 or 6, but not very many.
I mean-
Percentage-wise, it's rising as you get older.
I mean, 5 or 6, there are very few kids who would accept, really, I think, starting immunotherapy. Huh?
They do okay.
Yeah?
Now, we're talking about physically or mentally.
Yeah.
Oh, well,
Are the parents
You have 15-year-olds that don't get shots. It's actually doing skin tests. Sometimes the 2-year-old,
Yeah, it
it's
looks like
easier
we
to
got
do
a
it
lot
than
of
it is
material.
the teenager.
Well, yeah, because they count on their parents to say, this is good.
So just make sure you leave time for her.
I will be counting down.
Okay.
Wasn't Tillis?
Tillis was scheduled to give this, and
Right.
He's still in Italy, I think.
He's speaking Italian.
I have a picture of where he's at.
Is that true?
You have a picture of him?
Of where he's at.
Yeah.
Of him. But he sent me a picture.
Where is he?
Where he is in Italy. Somewhere near the
Told
coast.
me his itinerary.
In between things right
There's some sandwiches and fruit up there.
So, you say here, children's.
Yeah, Dan, his opinion.
You know, we got the pediatric. What do I need to talk
Oh, you want to sign this, or you allowed to sign this?
to? Why?
Well, I don't know if it was not.
That's him.
It's been listed
Unless
as
you
a
get,
published
do you have any home
sentence.
office skills?
Dr. Redding.
It's interesting, because even now when we leave like
Because they don't
literature
do-
behind,
they don't do
we have to
that.
document it. And
Well,
so,
I'll get a signature for it.
not a signature, but just put it into our system saying we left like a study or a piece of paper behind. And so there was one doctor who was
No.
reviewing the Sunshine Act, and he's like, why do I have like $7.15 under my name when I don't accept it?
Does
And
something cause that to run?
yeah, because basically it's like 15 cents per. So I just leave it with the nurses because you don't have to document it.
Have a seat.
Cover workarounds.
So there's one point in the quantity of giving you data.
The two, so the head of allergy is like from.
Oh, really?
Eric got that for his children.
See?
Where you know where you.
I'm getting smart all the time.
I'm good, and yourself?
I apologize for didn't mean to put my back to you.
No. This is what I wanted to give you.
I'm sorry?
Desensitization at Children's. If you email her, she'll come out. She's really, really powerful.
So do you have to go through the whole process? Like getting your back.
I just
Forward after.
Sure, for children.
what's your number?
299.
Put out my fires for me.
I had a good time. I thought it was really interesting, actually.
Did you just go there and back on the same day?
And yeah, it's a faster flight than
Yeah.
What is it, Will?
There's no.
it had been delayed for 2 hours.
Oh, really?
Through main entrance, and then
It was alright.
you go up 111, and there's like a
It's not Will?
more visual, but it's called.
That's okay. Okay, good.
Yeah.
Good, how about you? What their verbiage is when you start talking about young people under your.
It's just not, they won't do that.
I'm sorry?
They won't do that.
It was good.
So it's a little bit of sure, they're going to get information, and they're really
Let's talk more.
What are you talking about?
Food allergy research.
Oh,
So updated.
cool.
What's going on here?
I didn't really want to commit, actually. I was just, I'm not clear what she was actually even asking for. So I was like, what do you mean? So I'm kind of over it. I don't really want to take on like a Oh yeah, well, we're all taking different days. I'm not taking MSP.
What, insert?
I'm like trying to, I was trying to know what she was even texting up there.
They're setting records.
Still don't have a test list, so that should say something. Still waiting for you to give me yours.
If you buy one, I refer you, I get some sort of deal. Special referral.
If I buy one, then I want that.
I'm planning a trip down to San Jose to Eddie's graduation. They've got some nice high-speed chargers along the coast now.
Yeah, you have your computer in the car tells you where to go, doesn't it?
Yeah.
So when here's San Jose, I think Costa Rica.
No, San Jose, Santa Clara College
Santa Clara is beautiful.
is outside of San Jose. Yeah, not leaving the country, but
It's a pretty nice place.
Santa Clara?
Yeah,
Yeah, you've flown over it.
I've been there.
Really?
We had one of our friends and kids graduated from there. So we ended up at one of the colleges down there. I can't remember which one. As I remember, Sue saying, I live in that house. I live in that house.
Yes, exactly.
You need a better job before you live in
It's
that
like a
house.
dorm. No. You'd live there. Yeah, no question about it. Anyway. Anything you need? No?
I need the FDA.
Do you need anything? Your patient info or
Need that FDA approved Zoller.
it's coming. You know it's coming. You know it's coming. You know it's coming. It's actually going to knock your VP on. It's going to be good.
Just in general.
I mean, the Santa Clara protocol. Is that you know, 2 months on.
Yeah, I can do that.
And then 2 months during. And done.
Yeah, I'll look at
Whoever came up with that protocol.
Yeah.
it's good right here.
Is that right?
I know this kid.
Yeah.
That was just on the street.
I got it.
Going to his my dad, but he's got to go up.
Yeah.
This one, that, and it's just like, oh my god, well, that part of my life is so distant.
Don't tell them I.
When you
said
go
that.
after that, but next year we're after
That's the section I like the best.
I know. Tuesday.
No, we had Otter.
Good times, the old
You are
days.
Yakima.
They're all gone, aren't they?
Yeah, they are.
I was.
Yeah.
I was.
How was it?
Actually, I got exhausted. It's hard work. You know, at our age.
Yeah.
Came back from there. I was really tired.
Gotta come back to work to rest up from your vacation. That's a good vacation. I mean, you have to come back to work to rest up.
Yeah.
Yeah, we're fired with it, but no. Fired with it.
Fires?
Yeah. On vacation?
No, you're in Yakima.
Oh, yeah, oh, he's right over there.
Regular time.
So he stayed? You're like, what's going on? It's been forever. Can you throw this on?
And then I only like.
Did you ask them that?
No, I rationalized it because of the time difference.
Okay, they should take into consideration when they call it.
And then Friday night at 10:30.
What was in my phone like Sunday? Actually, it wasn't that. It was 8 a.m.
Journals did it last.
No.
Well, had 6 days of diarrhea and was dry. And the kid had baseline average.
There were two.
The white count was like
It looked different.
because the baseline was like 20 or 30. And he was a little down in all cylinders.
There's a lot going on in Montana right now. Like Bozeman got wiped out.
2 more mornings.
All of Joe's family got
Now apparently.
This patient was actually seen at Children's like earlier in the week and diarrhea.
Yeah, like when we were getting those Sunday morning calls from
Today's Troy and Hans Day.
Yeah, because
And Hans has 4.
Yeah, I did that.
It's nice to get.
Oh. You guys may be up by 8 o'clock. If you're at home. I don't know how. I saw Stolzman and his mom and still up before the 2 of us.
Good. What have you been up to?
I got like
Well, there's got like a few days last week. The carrier workout.
Tom always says we don't. I'll look come out and then someone's like, screening labs. You write down all these routines. It'll be late. I did actually. I ran that drove up to the corner on Wednesday.
Go to Tulip. Is it over or is it open for the Tulip? Oh, it's there.
Oh, yeah.
Very good.
They lost their best score. But let's go ahead and get started. Just a couple of announcements. The word of the day is food.
Yeah.
And we've got 2 speakers dividing it, and when I looked at the handouts, it's a lot of information, so I think these guys are going to go pretty quickly. 3 weeks from now is the last session of the year. It's the evening dinner reception. Everybody's welcome. It'll be at the building across the street. I think that's the 850 building. This is the 750 building in the evening. Start about 6:30. And the only other thing I have to say is, you're wondering why I'm wearing this shirt. This is National Wear Your Tablecloth to Work Day. 1, 2, 3 other people got the memo. All right, so Dan is going to kick this off, and he's got about a half an hour, and then he's got some research patients to get to.
All right. So this is normally something that Steve Tillis does. Yearly kind of update everybody on what's going on with research and food allergy in the Seattle area. That's what I'll be doing today. Here's my disclosures. This is where Steve is right now. He sent me this email yesterday. Yeah.
Oh, that's Cinque Terre,
That's very nice.
the Mediterranean coast.
So in between his visits here. All right, and Lisa says she's parking. She'll be right here. All right, so I'm going to do a little bit of introduction to the group and talk about the clinical studies, and then we'll talk about some of the clinical treatments available here in Seattle. So the first documented food allergy was back in 1912 by a pediatrician. And he diagnosed it with a relatively new technique of skin testing and confirmed with a food challenge, much like we do today. And that first allergen was egg that was described. Fatal food allergies, going back fast forwarding, wasn't really reported until the 80s. It was so notable that there were prominent journals with just case series describing fatal food allergies. Published in JAMA, published in the BMJ, and even the first line from the 1988 JAMA articles basically said that fatal food allergy is very extremely rare. Well, that was then, and this is now. So up to 15 million Americans have true food allergy. About 4% of adults, 8% of kids, and the number of adults are going up because the kids are turning into adults now. Between 1997 and 2011, there was 50% increase in food allergies in kids. We're not alone. Europeans and Australians have similar increases. In fact, Australia's about 10% of kids have it. Top allergens, as we all know in this room, are the peanuts and tree nuts, egg, milk, etc. The other thing that's happening is that milk and egg are taking much longer to resolve. So egg and milk allergy has been around for 100 years, but more than 100 years, probably for a long time, and that used to go away really quickly. Nowadays, you're going to see about 20% that will retain it into adulthood. And we actually have clinical trials where we have 17-year-olds who still have severe milk allergy, not even baked goods, can't even tolerate that. So estimated cost about $25 billion annually. This was the increase. This is hospital discharges with a food allergy diagnosis. This goes up to 2006. I couldn't find anything closer, but you can see that it's definitely increased between 1998 up into the 21st century. And I'm sure this number is also increasing as well. One of the things that we see here in what was going on here at NAC, 2008, there was about 6,000 office visits related to food allergy, which is about 33%. I just ran the numbers for 2016, over 13,000. Almost 60% of all office visits had a food allergy diagnosis, either follow-up or new patient, with anaphylaxis to a food product. So definitely a massively growing problem. Here's the current treatment, standard of care. Stay away from it, have an EpiPen, or an Auvi-Q, or an auto-injector. So at least we have options nowadays. One of my collaborators I'm working at Children's her name is Julie Brown. She did a study about EpiPen and the injuries that don't get reported by myelin. So there are some massive injuries. If you go too shallow with an EpiPen, the needle's pretty long, and you can get massive laceration across of it. I have one patient that has a nice big scar when her mom went very shallow. If you compare the needle length to things like Auvi-Q is a super tiny needle, and it's in and out within 2.5 seconds. So by the time that 5-second timer goes off, it's already out of the body, and so you don't have that possibility. The generic one is absolutely awful. I don't know if you've actually ever handled one. The needle stays out after deployment, and I've had one fire off in my hands by just taking off one of the safety caps. I almost never, if I can get away from it, never prescribe the Adrenaclick generic. Can we do better? I think we can do better. So we have multiple food allergy treatments that we're doing research on. Of course, the epicutaneous, which I'll be talking about, oral immunotherapy, gene therapy, and then the biological plus oral immunotherapy that I'll just gloss over because we don't have any active studies going on with that. All right, so desensitization. This is kind of the goal of most of the studies, of basically all of our food allergy studies going on today, which is essentially a change in threshold dose needed to cause an allergic reaction while the therapy is continued. This can be achieved through oral immunotherapy or epicutaneous. Lots of treatment side effects are common, but ultimately the goal is the so-called sustained unresponsiveness, or I like to call it the cure, which is really what people want, is complete resolution without need of ongoing therapy. So you can eat it whenever you want to. This is very difficult to achieve. There are At some point in the longer-term treatments, we have seen people's skin tests and IgEs go completely negative to specific foods, and their treatment can be extended out rather than daily to twice a week, 3 times a week, that kind of thing. But I've not yet seen anybody truly, I would say, have a true sustained unresponsiveness. At least I've not tried it. All right, so approving new food allergy treatments is a very tedious process. We have to go through phase 1, 2, 3, and 4. But luckily enough, the FDA has recognized that this is an active problem, and so currently both the phase 3 studies that we have going on right now are fast-tracked. So with likelihood, if everything goes well in these pivotal studies, most likely approval in late 2018, 2019, which is pretty fast. So the first patch study that we were involved with was the VIPE study, which began in 2013, and that was completed in 2016 with the long-term follow-up study. We have 3 other studies that are going on actively right now. So the pivotal phase 3 study called PEPEAT, that's completely enrolled, and that's ongoing right now. We're doing our first year of challenges going on right now. The PEPEAT folks are rolling over into the PEOPLE study. And then we also have this other study called a RELI study, which is a safety study for peanut patch. I'll talk about each one of these a little bit more detail in a moment. We also have the milk study as well that's going on right now, and that's the MILES study, and that's a phase 2 study. It has a dose range. Began in 2015, and we enrolled the very last patient in November 2016. And we're already starting to see the first kids from that going through their first post one year challenges. So the VIPES and OLPHUS VIPE study, and the OLPHUS was a continuation, was a double-blind, placebo-controlled, randomized trial to study that ViSkin peanut patch. And this was done for everybody from ages 6 all the way up to 55. There was 3 doses, 50, 100, and 250 micrograms versus placebo. And they had to have a challenge below 300 milligrams, so a total cumulative dose would have been 444. This is using the Practol guidelines. They had to have a pretty good size skin test and immunocap, with the primary endpoint either tenfold increase or to elicit symptoms. So here's the VIPES kind of big points here. We can see the changes right over here. So this is the mean cumulative reactive dose. So the mean change of cumulative reactive dose between placebo, not significant, but between the 50 microgram, 100 microgram, and the 250 microgram, you can see a dose-related response to the amount of peanut that they were able to be tolerated by 1 year post-study. But only about 54% of the kids had this positive response in the first year versus 19%. So it was significant, but certainly 50% not fantastic. One of the good things about it is that it has a pretty safe profile. There was no epinephrine needed, no serious adverse events, and so no anaphylaxis related directly to the patch. There was some epinephrine given, but it was for accidental ingestion for other things. What most of the kids had, and that's what I see on a regular basis whenever I see these kids in follow-up in research clinic, is that they have mild to severe reactions at the skin level on the patch site itself. So they could have pretty severe eczema, and so some of them really require a pretty moderate to high potency steroid to get it under control. But that gets better with time. And so for the OLPHUS VIPE study, they selected, because the most efficacious was 250 micrograms as the treatment going forward. So from here, we saw from the VIPE study, the responders, so this is again 10 times or greater than 1,000 reactive dose, 53% responded at the first year, and that comparatively at the end of the study, 83% had responded. So either 10 times or greater than 1,000 milligrams was tolerated at their challenge. This is the placebo kids from the first year, so 1 year, so it kind of replicated what was going on in the first year of the VIPE study.
What's the logistics of how long they wear it, when you replace it, that kind of thing?
So when they first put it on, we watch them in clinic for 3 hours to make sure that they don't have any serious reactions. I've never seen a serious reaction from the first day. Then for the first week or so, they have it on for 6 hours. So the first 2 weeks, and then they have it on for 12 hours. So for the first month, it's basically increasing the amount of time that they have placed on them. And then eventually they go on to 24 hours. So after the first month and a half or so, they go to full 24 hours. And so how we have it structured is that the parents will kind of time bath time or pool time around the time where they want to kind of swap it out. And so they kind of jump in the pool, go take a shower or whatever, take off the patch, put on the new one. And so it's supposed to be every day for at least 24 hours. A full day is considered between 24 to 26 hours. So they have to have a new patch every single day.
Do you make the patches and how, do you make them?
No, this is a company. So the
Yeah.
DBB. So that it's part of their kind of like, the company is really a patch company. And this is one of the aspects. They're looking at many different other things like vaccine delivery and other things. But they were an epicutaneous company, and this is what they first kind of jumped into. So they have this special kind of spray. It's like dry. And so essentially what happens is that when the patch goes onto the skin, I'll show you an example of it. I have a picture of it. That your sweat pools inside the chamber, dissolves the peanut protein, and then it goes into the dermis. And so from there, it contacts with the dendritic cells and antigen presenting cells, and it goes forward. It actually doesn't get into the bloodstream. So they have lots of elegant studies. They like to show this every single time of like that it doesn't really penetrate beyond that. It doesn't really get into the bloodstream. Now this is the data for the cumulative reactive dose over time. So this is 0, 12 months, 24 months, and 36 months, with the median reactive dose at 1.4 grams of peanut protein, compared to the median reactive dose at being at 44 milligrams when they started. So this number basically goes from 50% to 80%. So essentially the change between 24 and 36 months, the same percentage has that positive reaction, but the kids with longer are able to tolerate more. But the same percentage between the two, second year and third year, so about 80% we're able to get to this point. All right, and again, so very, very, almost all the adverse effects were mild to moderate skin severity. That's basically all you saw. Topical steroids, antihistamines is all that they really kind of needed. So very safe profile. This was replicated by the COFAR group, and so COFAR 6 was EPITS with the Bioskin peanuts, and they did it from ages 4 to 25 with 74 patients. And they did 2 doses, the 100 micrograms and 250 micrograms. And they found a very similar type of profile as well, that the 250 was the most effective dose. And pretty much exactly the same type of results. About 50% responded after the end of the first year. And so this is 1 year data versus 12%. And so either tenfold increase or tolerating up to a 5 gram, which is even higher than we challenged typically at year 1 for in the study. And very similar safety profile, no SAEs, reaction were predominantly local site. But this is one of the very key things about the advantage of this study was that 97% stuck with it. Only 1 patient dropout. This is in great contrast to typical OIT, where you can see anywhere from 20 to 30% dropouts because of tolerable side effects. Only 1 person did.
Remind me, what is 5 grams in number of peanuts?
So a typical peanut is about 240 milligrams. So we're talking in the neighborhood of like 2 Reese's peanut butter cups, 10, 15 peanuts. So pretty good amount. So
and compared to OIT, where they won't take people with fatal anaphylactic, all comers taken in this?
They won't take fatal, of course, but they won't take grade 4. They won't take grade 4 or above. But the Realize study, we do take grade 4s. Yeah. So the PEPIT study, this is the pivotal phase 3. Because one of the other things in the VIPE study, they found that the effective group of kids were only between the ages of 4 to 11. The adults weren't, so all that data I was showing you was only for that age group. The adults did not show a clinically significant or statistically significant change in their treatment. So that's actively being studied, whether a bigger patch, larger, more exposure, more time. That's being looked at right now. But no active studies going on for right now. It's kind of a scramble to get a product approved right now. So whoever hits the market first, they think it's going to be And so this is a 2-year open label follow-up with 265 patients being randomized to this, with basically replicating vibes, but only in young kids. So they had to have a history of clinical reaction, immunocap, and skin tests are right there. And essentially this, we're going through the first year follow-up. The patients are now rolling over into the PEOPLE study, which is the extended extension study, which is a 2 to 3 year open label extension, and they're challenged at the end of 3 years of therapy. So here's the basic structure of the study design. So either they're placebo versus patch, and everybody's being on the 250 microgram patch, because that's what the dose range was found from VIPES. They're challenged at the end of the year, and then they're challenged at the end of 2 years. So a total of 3 years of therapy. Or if they were in the placebo group, 1 year plus challenge, then 2 years challenge. Okay. All right, so one of the things that the FDA wanted, they didn't feel that 255 kids was enough to justify this to be considered safe. So they added on a safety study and what they wanted to do was kind of replicate what this would be like in the real world. So no pre-entry food challenges, because that's typically not something we would do in people who have these significant numbers. 3 years of therapy with the 6-month placebo control. Inclusion, they just had to have a history of documented reaction, and they specifically said that the reaction had to be over the age of 2. Immunocap had to be greater than 14, and skin test of greater than 8 millimeters, so they had to have both. And then, strong, no OFC, and we have completed enrollment for that study. The milk patch study is a phase 2 study, so again, this is the dosing range. So we have 150 micrograms, 300 micrograms, and 500 micrograms in the MILE study. Ages 2 to 17, with a good, both skin tests are greater than 6 and immunocap greater than 10. 1 year treatment plus 1 year open label. And so they had either 10-fold increase or a cumulative dose of 1.4 grams of milk protein. I had a couple of these kids go through so far, and we had some pretty serious home runs. We were able to tolerate almost 5 grams of milk after 1 year of therapy. And these were all kids that reacted at 10, 100 milligrams. So I've been surprised by how well some of them have responded. I've also seen other ones who did not budge a drop. So I have no idea if they're on placebo or not, or treatment. So we've completed enrollment for that one. Immune is the other big study that we're working with, along with BRI, who's also using this. This is a phase 3 peanut low-dose OIT. And so there's a pivotal phase 3 investigational product going on right now. Asthma Inc. is doing the pediatric folks, and BRI is doing the adult. And we've completed our recruitment. They're all moving, well, at least most of them are rolling over to the rollover study, which is another 2 years of therapy, or a year and a half of therapy. And then we have this new study called Ramseys. And this is a phase 3 peanut OIT study that's basically kind of like Realize. It's a safety study. The FDA wanted increased numbers. And both Asthma Inc. and BRI are running this, and it's ages 2 to 17 years of age. And we're going to start recruitment probably in May or June when this stuff kicks off. So target dose is 300 milligrams. So they have skin test was very minimal, and it's from 4 years old all the way up to adults. And this is essentially the dosing structure. So they come in and they start with a rush desensitization up to 10 milligrams. So they come in for their first day, you give them a half a milligram, 1 milligram, 3 milligrams, and then a 5 milligram dose, which is a total of 10. They do that on day 1. They come back the next day, and they go home on a dose of 3. You do a challenge dose of 3 milligrams, and that's the dose they start off with. And so they come in every 2 weeks for updosing, if they can, all the way up to 300 milligrams of total peanut protein of ingestion. It's essentially this kind of like gritty powder that they have to ingest in whatever way that they can. Kids hate this stuff. They really, really despise it. It's hard to get around it. A lot of them have that kind of intrinsic hatred towards peanut, and this tastes like peanut, unless it's placebo. Oftentimes, and if one of the things, if you start doing OIT in the not too distant future when this stuff gets approved, you're going to get phone calls. And so when they get sick, if they have a menstrual cycle, if they do something extreme exercise right after they get their dose, if they do all this other stuff, they have reactions, especially at the beginning. So there's going to be a lot of phone calls. It can be late phone calls if it's a teenager who likes to take their dose at midnight, which I have, and so they wake up, they're itchy at 2 o'clock in the morning. The Ramseys Study, again, this is going to be recruiting right now, very soon, from May to June. So if you have any patients who want to try to get involved in a study, kind of contact either our group or BRI, because this is going to be kind of a fast. These studies fill up very, very fast. We'll probably be done recruiting within a week. We have hundreds of patients kind of like ready to go. It's very, very easy studies to recruit into. This last study that we're involved with is a phase 1B study from the Astellas group. And this is a peanut gene vaccine. I made reference to this when I talked about gene therapy. It's a phase 1B, so this is a safety study in peanut allergic patients receiving ERA-LAMP vaccine, which is genetically encoded with ERA H1, 2, and 3. So it doesn't have peanut protein in it. It has the genes for peanut protein enclosed inside of a DNA plasmid. As I mentioned before, this is currently open enrollment. We're trying to get adults. This is 18 to 55. So if you have any adventurous peanut allergic adults in your practice who are interested in doing something kind of interesting, we want them. So they're not true peanut allergics are not adult peanut allergics are not necessarily easy to find who have the time to be able to do this. And so they have to have a history of peanut allergy and then pass a double-blind placebo-controlled trial. Dr. Jong had a similar experience when he was recruiting for his adults. I think he had recruited like 12 patients and had 8 went right through the double blinds, and so was only able to recruit 3 adults into the Palisade study, and he was the number 1 enroller of the study. So just to show you that adult allergy is a little bit different than kid allergy.
So pass, you mean fail? Have to prove still that they're peanut allergic?
Yes, exactly. That's what I mean. Yeah.
What? Okay, this
pass for me, so fail for them. So a naked plasma DNA is injected either intradermally or intramuscularly, and the thought is that it gets uptaken, and then the genes get expressed and has presentation to THC and antigen-presenting cells. So that's the basic idea of it. We'll see if it works. So why are we doing all this? This is a very interesting poster I saw at Quad AI this year, looking at from the Food Allergy Research Group. So they looked at the impact of changing your threshold from 10 milligrams to 300 milligrams, or 100 milligrams to 1,000 milligrams. And this is looking at food that has the label may contain nuts. Okay, and so by increasing your threshold from 10 milligrams to 300 milligrams, you can effectively reduce your risk of having a reaction to an unknown amount of peanut very significantly, like 99.9% in a lot of foods. And if you get up to 1,000 milligrams, you can go down to 99.9% for basically all packaged, nearly all packaged foods. So that's why we're doing this. Some of the side effects of food immunotherapy. One of the large concerns of oral immunotherapy in particular is EOE. And so only in the literature they report EOE positive if it's done by scope and biopsy. But quite a few patients, and I've seen it myself, who have these symptoms, all you do is say you stop immunotherapy and their symptoms get better. But we don't know what the kind of true incidence of this is. And so in collaboration with John Spergel and myself, we're working on a project right now to assess the true incidence of this food immunotherapy EOE-like disease, to see what the true incidence of this is. All right, so what's going on in Seattle? Well, we always have low-risk OFCs that we do routinely in our offices, lead challenge, etc. And we also have the high-risk OFCs available, which is staffed by many of the people in this room. And so the high-risk challenge clinic, just to remind everybody out there in the community what's available for, is a way to answer if they're allergic or not in a very safe way. This is available at Children's Hospital. It's inside the hospital ward. Requires 2 visits, a screen, and then a separate challenge on a separate day. And all the patients get a 1-to-1 nursing care with IV access, and then they're given titrating doses of their foods. They either pass or a reaction occurs and we treat them. Here's the River 4 where we have it. Here, that's a chair, but sometimes we have a bed. And they get hooked up to the monitors. Criteria 4 to 20 years of age, and we do most of the most common foods, so all the nuts, peanuts, sunflower, milk and egg, also pure and baked. They can't have unstable asthma, and if it's from an allergist, we'll challenge just about anybody. But this is only for kids, no adults. And the pro can come from anybody. I pulled some of the Seattle Children's OFC data just to take a look at it, and it's about 50-50 of the pass-fail rate. And a couple of interments, we had a few kind of folks get the vapors after they get their IV, and so they had a vasovagal. And a couple were stopped because they were just too nervous. Most common was peanuts, tree nuts, and then baked goods were the most common foods we treated, challenged. Research challenge clinics. Prior to 2012, there was none. In 2017, we have 3 sites now, all locally staffed. Our Ped CRC is the one that we do our pediatric challenges on, and we are actually recognized. The FDA came in and used us as a model for the safety profile that we had. Some other sites, for one of the studies, they had a physician on hand, except he was on campus, and some campuses are very large, which was about a 20-minute drive or so, so he wasn't really available. We also have adult research challenges, so BRI is doing it with the Palisade trial, and then we have our newest at UW. So we have done 2 challenges at UW CRC, and it was related to the SLS trial. Kicking and screaming, but we got it done, so they were willing to do it. Oops. Okay. All right, so clinical food became in therapy in 2017. OIT has been successfully performed in private practices. What we're doing is we're seeing a lot of the graduates of these food OIT studies. So they went through all this work, either through the multi-food study or through EPIT, and then they've tolerated a food challenge. They were able to eat 1.4 grams of whatever, and now they're out. So what do you do with these folks? And so we're trying to organize an approach to kind of transition these guys from the clinical studies to the kind of the OIT using equivalent foods. So I do challenges to it. So I've extrapolated patches to, or peanut OIT to peanut butter cups, and they like it much, much better. All right, so we have lots of things going on. We have about 70 patients in active food trials. We have 2 phase 3 trials, 2 phase 3 safety studies, a phase 2 milk study, phase 1B peanut study, ongoing collaboration going on. We have the high-risk treatment clinic, and we're evolving care right now in the treatment of food allergies. There's more to come in the not-too-distant future. More on that later on. But that's really all I have to talk about, and I think I have left plenty of time to talk. So, any questions for me before I run off?
And in the 50% of people who passed the challenge over at children, you know the subsequent outcome? Are they eating the food successfully? Are they still afraid to eat the food, even going through all of that?
That I don't know. We don't track them. So the OFC, the risk clinic is just that. So we don't do follow-up with them. How my practice is basically telling them to either follow up with a primary allergist and say, this is what I usually do is I'll take a reactive dose, cut it by 25%, and say this is where we're going to start. So a lot of these kids, while they react, they're reacting at pretty high doses, like 10 peanuts, 20 peanuts. And to have those kids completely cut peanut out of their diet makes absolutely no sense. Those are definitely kids who could tolerate a peanut a day. And so I kind of use that as a jumping off point. If they reacted right off the bat at like a half a peanut, then we're done. You need to be in some sort of food therapy. But if you're reacting at much higher doses, extrapolate from there. And whether or not that actually gets followed with the recommendations to the primary allergist, I don't know.
Ones who pass the challenge,
yeah,
it would be a shame to put them through all of that, and then they still have a paranoia or a fear not to continue ingestion. It would be a waste of effort.
Yeah, it's definitely a challenge. We've had to send quite a few kids to psychologists and therapists because in our OIT clinics, I've had to let some patients, we had to basically say stop. The anxiety, especially I find the boys, like 8, 9, 10-year-old boys have tremendous anxiety, especially the highly intelligent ones. They just it's all about risk for them, and just I don't want this, I don't want to have this, I don't want to have all these bad things can happen, and they just go into this fear spiral. And I've unfortunately broken a few kids, so they need to see that therapist. Yeah. So it's not for everybody. This food immunotherapy is definitely not for everybody. You have to pick and choose the right people to be involved with this. Yeah.
So presumably these children, some of them have more than just peanut allergies. So how do you approach that? I mean, you don't have to be just peanut allergic to enter these trials, or do you?
No, most of these kids are multi-food. So it's whatever the parents want to do. So in fact, most of the milk kids are probably also peanut as well. And so it's kind of whatever they choose to be in these studies. And once they're in the studies, they can't be on any sort of like immunotherapy. So you can't do kind of home dosing and other things when they're in this without very special exceptions from the sponsor as well.
When you do the patches, how long after you pull the patches off do these people show protection?
You mean in terms of like longevity?
Yeah, like if you do 3 years of a patch, then at 4 years or 5 years, do they revert back to where they were?
That's a very good question. That's to be answered. Yeah. So we're right now. So the longest people have been on it. So 2013. So 3 years. The only people who've been off patch for only about a year. And most of those kids have been followed up with these kids, and a lot of them extrapolated into like a peanut oral dose equivalent. So whether they completely stop, nobody's done that type of thing yet. But it surely should be a phase 4 type study. Yeah.
You had a certain subset that developed eczema or dermatitis from those patches.
For sure.
Is their outcome any different than the ones that did?
You know, the ones who react seem to do the best, really. And so the eczematous kids, I found to have the biggest home runs, honestly. One of the best kids I saw was this terribly eczematous teenager. He had scars from his patch. That's how bad his eczema was. But he was so excited because he can eat peanut butter cups now. So he didn't care. But yeah, so they seem to really respond really quite well. The ones that have absolutely no skin response tend not to do so well.
Here's a question from outside. Are you accepting FPIES related challenges to children?
No, not yet. Working on it, though. Working on it.
All right, let's transition. I think Lisa's got another full half hour on food for us. Thanks, Dan.
So I'm going to talk to you guys today about some recent studies and publications, just talking about various approaches for desensitizing food allergic patients. So this will kind of overlap a little bit with what Dan was talking about, but I'll try not to reiterate what he said in too much detail. Just a few studies that I'm involved with through Seattle Children's and through the Asthma. Okay, so I'm going to focus on the epicutaneous immunotherapy with peanut, like we discussed a little bit, but I'm going to go into more detail on the COFAR study specifically, the one that was just published in the April publication of Jackie. And then I'm going to talk about a few other modalities. There was an abstract from the Quadai about peanut slits. We'll touch on that briefly. There was another one that talked about peanut OIT using probiotics, which is kind of a follow-up to a study that was published a couple of years ago that actually presented a few years back. So I'll talk about that briefly as well. And then there was another abstract at Quadai this year as well as last year, kind of following a group that's doing walnut oral immunotherapy and also looking at how that may help desensitize to other tree nuts in addition just doing walnut. So I'll try and touch on all of these briefly. So this was the COFAR study that Dan had referenced that was published recently looking at epicutaneous immunotherapy in children and young adults for peanut allergy. And again, this was kind of based on vibes, but a little bit different. So this was, again, a group that just used the 2 doses, the 100 and the 250 microgram patches. Again, they're still using the Viaskin peanut product. And their primary endpoint, they had 2 varying definitions. Again, one of them was to reach that 5 grams, that higher dose of referenced, and that was at the end of 52 weeks of wearing the patches. Or the alternative primary endpoint was to just have a tenfold increase. And we'll go over the data, but this is kind of a very different primary endpoints depending on which definition you look at. So again, tenfold or greater increase from the baseline successfully consumed dose, which they call the SCB. And then we looked at other various secondary endpoints, including IgE, IgG levels, and other signs of modulation and safety, of course. So inclusion criteria very similar to what Dan had referenced before. This was mostly children and young adults. They had to have positive skin prick tests and or IgE levels. And in terms of the positive baseline challenge, they tried to challenge them to up to 1,000 milligrams, a little bit over that in terms of the cumulative dose. Again, they do exclude those who have a history of severe anaphylaxis in this study as well. This is just a picture. You kind of discussed this already in terms of what the peanut patch does. It has this little reservoir containing the antigen that gets you sort of the skin. You guys,
how they make the antigen? Is it just desiccated peanut or anything more complex than that?
I don't know a ton about how the patches themselves are made. Dan may have more info just from working more closely with DBV. So yeah, I'm not sure exactly. You've asked a bit about the way the patch is worn, so they have a little bit of variation, and this is consistent with vibes in terms of older kids can use it on their arm, or adults and children it's put on the back between the scapula. And then they rotate it every day, so they kind of rotate it in 6 different locations because you don't want to put it in the exact same place where it's been previously causing the eczematous reactions and whatnot. And then in terms of the dosing, as he referenced, first week you wear it about 3 hours a day, and then that time doubles each week until they're up to 24 hours a day. They did have to be seen on site the first day or two to monitor for any adverse reactions. Again, most commonly these were local reactions. If it was a really significant one, then they may adjust the time that it's worn and have kind of a more gradual increase in their dosing. They were allowed to still treat these reactions with topicals, but they couldn't put anything too close to the actual patch site aside from some 1% hydrocortisone. And then this is just a grading scale of the types of reactions. So again, they went grade 1, grade 2, grade 3, grade 4, and the majority of the ones they reported were on the milder side. There was only a couple grade 4, I think that they mentioned. They'll go over that in a little bit more detail. And then we talked about this a little bit, but the challenge at baseline again was to cumulative dose of a little over 1,000 milligrams of peanut, and then the end challenge at the end of the 52 weeks was supposed to be to up to 5 grams or 5,000 milligrams. They collected skin prick tests at various time points and also looked at IgE, IgG levels, and various other assays to kind of assess what's going on immunologically. Just a breakdown of who was in what group. If you go down to the bottom there, you'll see that the amount that completed each placebo, the 100 microgram and 250 microgram patch, was all about 22, 21, 25. There were very few dropouts, as Dan had referenced. A few people that stopped because of reactions or non-compliance, but overall very well complied with over time. This is kind of the baseline demographics between groups. The most important part that I thought was interesting was down at the bottom where it talks about the amount that was successfully consumed dose at the baseline challenge. So again, the placebo group, the median successfully consumed dose was 44 milligrams, same with the 100, and in the 250 group it was 14. So overall these kids were quite reactive at baseline in terms of the amount that they were able to consume. And the most anyone consumed in any of these groups was about 444 milligrams. So they looked at the primary endpoint. Again, that was either people who were passing the end challenge of up to 5 grams or people who had a tenfold increase. Now, if you'll recall, most people reacted, the median reactive dose for most of these people was 44 milligrams in all groups. So a tenfold increase was really putting you at about 440 milligrams consumed at the end, which is pretty small when you're looking at comparing to anyone who may have consumed a total of 5 grams. So again, if they use that kind of looser endpoint of tenfold increase or tolerating the end challenge, they were able to say in the 100 and 250 groups, 45-48% endpoint compared to 12% of the placebo group. But they did an ad hoc analysis trying to be a little bit more stringent and said, let's look at those who just were able to consume more than 1,000 milligrams or so cumulatively at the end. And those numbers changed pretty significantly. In the 100 group and the 250 group, that dropped to about 12.5% or 28%. So again, still some increase in what you're seeing with the 250 versus 100. But then again, being even more stringent, they looked at those who were able to tolerate at least 1,000 milligrams from the 1044, and also have a tenfold increase from their baseline reaction, and those numbers decreased even more so. So in the 100 and 250 groups, that dropped to 8.3% and 16% compared to almost 50% if you use that looser criteria of just a tenfold increase. And again, this is just showing the overall change in baseline that people had from the baseline challenge to the 52 challenge in terms of what was able to be consumed. And they basically showed that with the 100 and 250 microgram doses, the change was slightly more significant in 250 versus 100. They were able to tolerate a total change of 130 milligrams from baseline when you were on the 250 patch versus just 43 milligrams, and that was the median change. Interestingly, when you look at the minimum and maximum amounts that were able to be successfully consumed, the group that there was only one person actually who was able to pass the N challenge and tolerate 5 grams of peanut protein. They happened to be in the placebo group. So if you look at those in the 100 and 250, the maximum amount that was met at the 52-week challenge was only up to 2 grams per both those groups.
What do the minus symbols mean? People tolerated less?
Yes, so some people reacted at earlier doses with the N challenge. And that's the minimum, so that was not the majority of people, but there were a few people that didn't tolerate as much as they had at the baseline.
Actually, these are pretty busy slides, so use the pointer because somebody my age, I have no idea what numbers you're pointing to.
On the pad. Just the pad.
Okay.
Yeah.
I'll use the mouse then. Okay, so kind of the main point from the slide, as I was saying, is that you're looking at the median change in what they were able to successfully consume from the baseline to the end study, and you see a bigger amount here with the 250 patch versus the 100, but in terms of how much more peanut protein these people are passing challenges to beginning to end, it was not a huge change in this study. And again, this is just over 12 months, so Dan referenced the studies looking at 3 years and how that's a little bit higher than what we see there. Dan, go ahead.
Looks like these are sort of the opposite results that Dan just presented.
Yeah, so he didn't go over the COFAR study in too much detail. And again, this is kind of preliminary data from the first 12 months, so they kind of say at the end, with continued treatment over the next 2 years or so, as they did with the OPA study, which was looking at a total of 36 months, we expect to see further and further benefits.
But this is the same patch by the same man. He just gave a glowing, report on this device.
I think the bottom line, both from that study and this study, is that yes, about 50%, as he said, were able to meet that endpoint of increasing your baseline challenge dose consumed by about tenfold. But again, the median was 44 milligrams, so if you're increasing that by tenfold, you're tolerating about 440, which is what he showed from the first 12 months. And then with the year 2 and year 3 in his data, it went up to about 1,400 milligrams as the median successfully consumed dose. So there is suggestion that with continued treatment over year 2, year 3, you will see further increase from that. But I think the point is, in the first year or so, the increase is quite modest.
The difference really is, do people no longer have to be fearful about small amounts of inadvertent ingestion?
Right. So I think,
or are you getting to the point where they can just ad-lib?
Right. When we talk about the various forms of immunotherapy, the epicutaneous certainly is probably the safest in terms of most reactions are just local. But in terms of the amount of desensitization that's occurring, it's quite a lot less. A smaller magnitude when you compare that to sublingual, oral immunotherapy, but then there's increased risks and less compliance with those endomodes. So you kind of have to pick, if these were all things that were widely available, you have to kind of choose the patient and say, what's your goal, what's your risk here, what's the best therapy for you. They definitely have different individuals that they might work well for versus others they may not. But yes, the overall data is not super significant with regards to preliminary desensitization in the first year or so of therapy. Okay, this is a very busy slide, so I'll try and...
Well, Lisa, isn't it also an age issue?
Yes.
I mean,
So
the older you are, the harder it is to do this.
So this is where they looked at that in this particular table, table 4 here. So when you break it down, looking at those greater than 11 versus those that are the 4 to 11 age group, let me try and move my mouse here. Okay, so the 4 to 11 group, when we're talking about those who are able to have treatment success, so again, that's a tenfold increase from baseline in terms of what they're able to tolerate in the challenge. And we said that was around 50% of all comers for both the 100 and the 250. Well, they're all basically less than 11 ones that are doing this. So let me see where my mouse is here. Okay. So the 4 to 11 group in the 100 patch, we had 10 people, so about 58% of kids less than 11 who were responders. And again, for the 250 patch, it is 11 versus 1 in the over 11 age group and versus 1 in the 100 patch in the over 11 age group. So the majority of kids that are responding, again, when you use those kind of looser definition of just having an increase tenfold in what they're able to tolerate, are those younger kids. And so this study wasn't particularly designed to break it down by age, but they did this analysis after the fact, saying, yeah, we do see a statistically significant difference depending on age. And so that was something that Dan alluded to as well, that I'm sure further studies will look into more detail in terms of why that is and maybe what needs to be done, if anything, to try and make older kids and adults have more success with this therapy. Again, when you looked at the stricter definitions of tolerating the larger amount of protein up to 1044 milligrams, or those who are able to tolerate 1044 milligrams and have a tenfold increase, the numbers decrease quite significantly, but again are generally greater in the younger age group than they are in the older age group.
Did you, just as a segue, did you see any late reactions where the patches were on, like at the beginning where it's on, you'd see nothing, and then the kids would call 3 days or 2 days later and say that there was like a patch?
So they were rotating the patch sites every day, and so generally the patch site reactions last for a while too, so they'll have an eczema flare there. But I'll talk about the kind of statistics on the reactions in this next slide here. But in terms of delayed reactions, I don't know so much about people calling in to say days later. They may notice it more then because the patch is in a different location since they're moving it every 24 hours, and they can still see any eczematous flare or reaction from the prior patch sites. But I didn't hear a lot about people calling in, complaining about reactions from a couple days prior from that site, a few days prior. But overall, in terms of reactions, as you may expect, there were much higher amounts with the 100 and 250 patch versus placebo. The majority of these were mild, though no greater 3 or 4 reactions with the placebo, and a few with the higher patches, the 100 and the 250. There's actually only 1 grade 4 reaction, and that occurred on the 100 microgram patch. But otherwise, kind of mild to moderate local reactions was what we mostly saw. And then reactions beyond the patch site occasionally occurred, but again, that was pretty low in comparison to total amount of reactions that were occurring. And so the conclusions from the COFAR study was that similarly to what we saw with Fipes and Olfus, this seemed to be relatively safe, and the majority of reactions were local, no severe reactions, no anaphylactic reactions. It was generally well tolerated, very low dropout rate, and was potentially effective, meaning there was some what they called modest improvement, although I think that might be overstating it, at least at the 12-month time point. And then I didn't go over this in great detail, but they did see evidence consistent with other studies about IgE levels to peanut dropping, IgG levels rising, as you would see in OIT and SLIP trials. And then they did make the comment that they saw the more significant increase in terms of the successfully consumed just from baseline to the end of the study in the 4 to 11 year age group compared to the placebo, compared to the older kids for both the 250 and 100 patch compared to placebo. They did also mention they did not see a significant effect with regards to participants if they just looked at those more stringent requirements of needing at least a successfully consumed dose of greater than 1044 milligrams, or those who were supposed to have a tenfold increase and have consumed over 1044 milligrams. That did not seem to be something that was happening across the board. Again, more common in the younger age group, but not something that was significant with regards to people that were able to do that. And as I mentioned before, only 1 subject passed the end study challenge completely tolerating the 5-gram dose, and they happened to be on placebo. So that was not something that they were able to do with this study. So this kind of goes back to what we were talking about, the comparing and contrasting different modalities for the epicutaneous therapy. They said for this study, we had a statistically significant increase in the amount that was able to be consumed from baseline to the end of the study, but that increase, the median increase, of course, for the 250 was only 130 milligrams, for 100 was only 43 milligrams. When you compare that to oral immunotherapy, of course, they're going to say EPID is much safer and better tolerated. but the amount of food that's being challenged and successfully consumed in a lot of the OIT trials can be up to 5 to 10 grams more than what they tolerated at baseline. So it's very significant. In terms of the sublingual, it's kind of middle of the road. You get, again, fewer adverse reactions than you're going to have with oral immunotherapy, but the changes in the successfully consumed dose are more modest, more so than what you might see with EPIT. A prior COFAR study had noted the median amount that people were able to tolerate pre and post was about 500 milligram difference for slit to peanut. But again, that may be over a longer time point, I'm not sure. So the main point that they came to at the end of this study was that longer term data was needed because as the OLFA study from VIPES, the follow-up study there showed at the end of year 2 and year 3, people were able to increase the amount that they were able to tolerate. So bottom line, as we said, this would be a good therapy for reducing risk of cross-contamination, but not necessarily approaching a level where you're going to be eating peanut butter sandwiches and be more truly desensitized. If you're looking for that, the oral immunotherapy route seems to be more prudent. And then some limitations, as they said, they did not have a sufficiently stringent primary endpoint to really be able to say much with regards to what they saw. They did exclude those with severe anaphylaxis, including that may have made a difference, probably not positively for them. And then age did appear to be an important factor that they didn't really take into account when designing the study, so further studies may look into that in more detail. This was just an abstract. I think this is actually the data that Dan had just presented, where it's looking at the long-term follow-up, and so again, this is after 36 months of therapy with the patch. And just reiterating, the VIPES was the 3 different concentrations of patch. It says milligrams, it's supposed to say micrograms, 50, 100, and 250 micrograms for 12 months. And then the open label follow-up study that was just doing the 250 microgram patch for an additional 24 months. So these are the numbers that he had presented at the end of that 3 years of wearing the patch. They were able to see a greater proportion of people reaching their endpoints, which again were at the end of that 24-month follow-up to be able to consume more than 1,000 milligrams of peanut, or again that 10-fold increase of what they were able to do at the baseline.
Do you know what the dropout rate is? Just thinking of someone putting a patch on every day for 3 years.
Right. So I think with this one, they said overall compliance was 95%. So they didn't have a very big dropout rate. I don't know exactly how many individuals that amounted to. But in terms of the people meeting the primary endpoint, here they said 80%, again, less than 11 years old, but 80% had enhanced efficacy with regards to what they were able to consume at the end of 36 months. But that, again, isn't exactly defined in the abstract in terms of, does that mean they increased from 400 to 1,000, or what exactly we're seeing at that point? Because the primary endpoint, again, is just a 10-fold increase from what they were able to do at baseline.
Let's see, we've got another question
Yeah.
here. Is there anything unique about the one in the placebo who outgrew it? Yeah, I was thinking the same thing. Did they study immunologic parameters? Did that person spontaneously lose their IgE and develop IgG4?
They didn't go into a lot of detail about that particular person. I'm not sure what their baseline reactive dose was. They were able to have them eat up to 10.4 milligrams of peanut in the baseline, so perhaps that person had a higher baseline challenge and was just naturally outgrowing peanut allergy. They did not but bottom line, the median cumulative reactive dose, they mentioned again, for VIPES at the entry was 44 milligrams of peanut, and then after 3 years of the peanut patch therapy rose to 1440. So that does seem to say there is improved benefit with further peanut patch therapy, because again, the COFAR study was only at the 12-month point, and their kind of median dose after 1 year was in the 440 range. So longer-term data may be helpful with regards to this. Okay, moving on. So a few other abstracts to touch on with regards to other modalities of immunotherapy. This is sublingual peanut immunotherapy. And this is something that isn't as widely studied as OIT and more recently the EPIT, but there has been some success previously. There was a placebo-controlled randomized controlled trial doing peanut slit. 12 months of therapy, they ended up getting them on a maintenance dose of about 2 milligrams per day via those drops under the tongue. And they found that people had a median reaction threshold of 10 milligrams of peanut protein towards the end of that study. So seemed to be able to get to higher doses than what we've seen with EPIT after just a year of treatment. And so this particular study was kind of trying to replicate that, but determine if using a higher maintenance dose and doing therapy beyond a year would lead to a more robust response. They had 55 subjects that they enrolled. They were on a maintenance dose of up to 4 milligrams per day. Again, that's double what the prior study had done. And they continued them on this for a total of 48 months. At the end, they wanted them to try and tolerate up to 5,000 milligrams or 5 grams of peanuts. Again, the amount that was generally tolerated with the prior trial was 1710. So here, they found at baseline, the most common was that people really didn't tolerate any significant amount of peanut, but after, it's supposed to say 48 months, not 48 weeks. After 48 months, which is 40 years of therapy, the median successfully consumed dose went up to 2,900 milligrams. And some were able to tolerate up to that 5 gram amount, some not so much. Again, this is only 14 subjects that they had info for at this point, so it's a relatively small N. But they are basically saying we were able to get up to a higher dose than that 1710 that was seen with just a year of therapy at a lower maintenance dose. So potentially higher maintenance dose of SLIT for longer periods of time may be more effective in terms of the desensitization than what was seen in previous publications. And again, this is just preliminary data for that.
I hate to digress, but I mean that's a research study, but this is going on in our community here,
right.
In clinical practice, which I think is inappropriate, because it really is not an approved technique.
Right.
But I'm sure some of you have been aware of that.
Right. And I don't know the details of maintenance doses that are being used in the community and whether or not they approach what these studies have done. Overall, the SLIT is not as well studied for food allergy desensitization compared to other modalities. Just going to touch on this briefly. This was a presentation that an article that I presented on a while back. I was trying to look at whether or not adding probiotics to peanut OIT would enhance the overall effect of desensitization. And there's various reasons, which I won't go into, about why that may or may not be helpful. But basically, this was also supposed to be looking at sustained unresponsiveness, which is kind of something we touched on earlier, at ability to basically have a permanent effect after you do one of these immunotherapy trials, so that you're able to come off the therapy but maintain that level of desensitization that you had previously. And there's been a lot of OIT studies that have looked at what we call sustained unresponsiveness. Usually the periods that they'll try people off of the foods for is in the 4 to 8 week range. It's not a very long period of time. And then they try and challenge them again to whatever their amount of food that they deemed in the prior challenge to see, are they able to maintain that amount of desensitization. So in this study, people were on peanut OIT with a probiotic or placebo. So they really didn't have another arm to look at peanut OIT alone or probiotic alone to see if that had an additive effect. They did, I believe, 18 months of desensitization, and then they challenged them, and then they had a period of what we call elimination off of the OIT, and they challenged them again at a T2 time point, and that period in between T1 and T2, they're looking for a sustained unresponsiveness while off of therapy. This is just the kind of typical day one rush, build up to slowly increasing doses over every 2 weeks, and then a maintenance phase. So the total duration of this therapy was 18 months. And then at the end, their first challenge, T1, was to 4 grams of peanut protein. Then they had a second challenge at T2. And the interesting part about this is, as I mentioned, most prior studies looking at sustained unresponsiveness had people off therapy for a period of about 4 to 8 weeks. In this case, it was 2+ weeks, so not as long of a period as what we've seen in previous studies before they challenged them again. And that's shown here. So they had the time point at T1 and then T2, where they had the 2 challenges, and then they looked at whether they were able to still maintain that previous level of desensitization to determine if they had possible sustained unresponsiveness. What they found, again, the median interval between T1 and T2 was 2.3 weeks, so not really on par with the kind of 4 to 8 week period that most prior studies looking at potential sustained unresponsiveness had used. What they found was that those who were in the peanut plus probiotic OIT group had a higher rate of desensitization compared to placebo, and that when they challenged them at the T2 time point, a good majority of them were still desensitized. So they said they had possible sustained unresponsiveness. Again, that challenge for most was only about 2 weeks later. And so they said, overall this seemed to be associated with better desensitization, decreased skin test response, and IgE levels, as you may assume that would happen. And again, this just shows that the few that did not successfully complete the first challenge, the doses that they were able to get up to in the peanut plus probiotic OIT group. And then mentioned that those who were able to successfully pass both challenges continued to eat peanut. I'm not going to go over the adverse events with regards to this study, but I think what's important to focus on, these are the strengths. They again said, overall, people complied well. They had a placebo group, which was good because some OIT trials previously have not had a placebo group. And there was a very low rate of possible sustained unresponsiveness in the placebo group, meaning most of those people probably kind of naturally outgrew their peanut allergy, but there wasn't a very high rate of that, so that overall made it a stronger study. But I think the important part with this study is limitations. They're trying to say, does adding probiotic to oral immunotherapy help desensitize people better? And we really can't say that without having a probiotic alone group for comparison or peanut OIT group alone for comparison. They also tried to say that overall they had higher levels of sustained unresponsiveness compared to prior studies where they've taken 40 groups off of their OIT. In those groups, they'd say 50% maybe continue to have desensitization. And so in this case, that 2-week period of being off of the OIT, I think, doesn't necessarily translate into a higher percent as they're trying to claim. There was an abstract this year that basically was a follow-up study from this probiotic plus peanut OIT. And they said after 4 to 5 years, they were kind of reflecting to see how people were doing after the study. This is kind of busy to look at, but basically found that those who had been on OIT and probiotic compared to placebo were more likely to still be eating peanut in a moderate to large amount, and 80% of those who had attained what they called possible sustained unresponsiveness were still eating peanut. Again, after that approximately 2-week period off of therapy, they didn't comment on whether they took longer periods off therapy or if they just went right back to eating peanut, but they said 80% were still eating some amount of peanut, and that was defined as anywhere from a few peanuts to a few tablespoons of peanut butter per week, so kind of varying amounts. Overall, those who had been on the peanut OIT plus probiotic had lower skin prick tests and IgE levels compared to placebo. And they said 58% at some point were able to do an 8-week period off of therapy and continue to maintain that level of desensitization again. Much smaller N than what they had in their prior study, and other kind of peanut OIT and other studies that have done periods off of therapy for up to 8 weeks, 50% is kind of what we've seen in the past as well. So not a whole lot different. So again, they're saying, this has long-lasting clinical benefits, but I'm still not convinced that the probiotic is adding anything, as they really hadn't had any kind of comparison groups to be able to show that this effect was due to having probiotic plus peanut OIT on board. How am I on time here? I think I'm getting towards the end.
We're 8 o'clock, is it?
Yep.
Okay, so I'll let you guys look over these other ones yourself. But the last couple abstracts in here were about walnut OIT. Basically looking at desensitizing people to walnut plus a possible other tree nut. So they challenged them to walnut, but also to either pecan, cashew, hazelnut, pistachio, and in the end concluded that desensitizing people to walnut may also be beneficial for some of these other tree nuts. Which makes sense if you think about walnut, pecan, crafts reactivity. They didn't necessarily specify how many people in the end they were able to pass both the walnut and test tree nut challenges. Because of pecan versus cashew or pistachio, but basically stating that if you just desensitize people to walnut with walnut OIT, you may be able to actually also desensitize them to another tree nut. So you can look over that data on your own.
I hate to say this, but the summary is this is a tough nut to crack.
Yes.
So Dan gave a very optimistic, what I thought was a very optimistic future for peanut and food desensitization. This is more realistic.
I think it's important to be realistic.
Yeah.
Still work to be done.
Yeah. Bottom line, cross-contamination risk is going to be reduced, but in terms of a cure, which a lot of people are looking for, we're not there.
This is partly what community science studies.
Oh, yeah.
Oh, well, I didn't want to mention names, but I mean, this is...
Maybe if you require more than one slide, you don't have to do it.
Charging people massive
How's it going?
Good, how are you? Are you up front here or is it Dan?
I was supposed to be on Thursday, but now he's having me do the CRC because he can't technically be there for the in challenge for a patient he'd already been on.
All right.
Yeah.
Upstairs.
Must be nice to almost be done. Yeah.
Sound good?
Okay,
You got good questions from the respondents. So.
I gotta meet somebody at my home, so.
Definitely. We'll have fun. Not till late-ish.
Bye.
Yay! That'll be so much fun. I know somebody's asking. Maybe there's time to answer it.